Hi guys, welcome to this video module on HIV. Okay, HIV is not just a topic, it is a vast subject in itself, right? Probably we should start having a HIV DM course as such, right? It's a vast topic. Now, it's a vast topic for everybody. It's not just for general medicine, for pharmacologists, for microbiologists, for PSM people, and for surgeons, for everyone, it is a major topic, right? So, as I said, it has evolved into being a subject itself, not just a topic, right? So today's focus is on very concise discussion of HIV. We're not trying to make it as a separate subject. This is a very concise discussion of HIV. So we will be going through important MCQ areas rather than trying to do a very much deep dive, right? Okay, so the first MCQ area I'm addressing is the risk of transmission. Right? One thing we standardly know, what is the risk of transmission following a needle stick injury? This is something that we know from our MBBS days itself, because we do get pricked, and then after that for a month we are like kind of depressed and pissed off, right? So the risk of transmission after needle stick injury is how much? 0.03%. This is like a golden number that every MBBS students in the country knows, right? Okay, so MBBS students may not know, like some of the students might answer what is the cause for diabetes mellitus. They might give you a wrong answer, but they definitely know this 0.03% as a number, right? Okay, now in terms of the risk of transmission, right, highest risk of transmission is through blood transfusion. So if someone receives the HIV infected blood, he has the highest risk of acquiring HIV infection, right? So the risk exceeds 97%, right? 97 to 99% is the risk of transmission through blood transfusion. Okay, then in the list comes the mother to child transmission, right? Mother to child transmission. Now when we talk about mother to child transmission, we clearly know the maximum risk is during birthing or during delivery, right? That is the time of maximum risk, right? So here the risk of transmission is 30 to 35%, right? Okay, now apart from that, the next in queue is a form of sexual transmission, receptive anal intercourse. So the risk of sexual transmission depends on various factors. Obviously, the infective patient's stage and his viral load, but apart from that, the nature of sexual intercourse, right? So in terms of the nature of sexual intercourse, it is the anal route which is associated with the highest risk of transmission of HIV infection, right? In comparison to vaginal intercourse, in comparison to oral intercourse. So oral intercourse is on the fag end where there is a minimal risk. Then you have vaginal intercourse, and then you have anal intercourse. There also risk depends on who is the infected person and who is infected person and who is not infected person, like particularly when we talk about vaginal or anal intercourse, right? So highest risk in terms of sexual mode of transmission is with respect to receptive anal intercourse. That means here we are talking about a patient, right, who is negative and he is involving in receptive anal intercourse, and the positive patient is involved in insertive anal intercourse, right? Insertive anal intercourse. In such situation, the person, the one who was negative, who is engaging in receptive anal intercourse, runs the risk of acquiring HIV infection, right? If you flip the scenario, the risk is not as high as we are talking here, right? If the person who is having HIV positive, right? The person who is HIV positive, he is involved in receptive anal intercourse, and then we have a negative person who is into insertive anal intercourse, right? The risk is not as high as the scenario that I just spoke about, right? So the person who is involved in receptive anal intercourse, if he is negative and his partner is positive, then there is a highest risk of this person acquiring HIV infection. I hope I have made that point clear, right? So next in queue is IV drug abuse. Right? IV drug abuse is also very important risk factor for HIV transmission. The needle injury we have already discussed, right? That is 0.03%. Okay, so this is the hierarchy of risk of transmission. Now, if there is an MCQ asking you what is the most common mode of transmission of HIV infection, it is not blood transfusion, right? Blood transfusion probably would fall far away, right? So the most common mode of transmission is usually through sexual route itself, right? It is usually through sexual route itself. It accounts for around 88 to 94% of cases of HIV, right? So these are the two MCQ points we have addressed. Now, having understood about the transmission, let us take a look at the HIV virus per se, right? So HIV virus, as we all know, it is a RNA virus, right? It's an RNA virus. Now it has a lipid viral envelope with some proteins encompass that on the viral envelope, and then we have some matrix proteins, and then we have core proteins and a nucleocapsid, and inside the nucleocapsid there is genetic material and some proteins and enzymes required for the viral cell metabolism, right? So on this lipid envelope viral envelope, we have two important proteins. One is GP120, right? Why is this important? Because this is the one which is going to bind to our CD4 receptors, right? GP120, right? And this GP120 is the one that is anchored on another protein called as GP41, right? It is anchored on a protein called as GP41. Okay, so these are the two important proteins we should know. Okay, apart from that, we have a protein called as P17, right, which is a matrix protein, right? This P17 is forming the matrix of the viral cell, right? It is forming the matrix of the viral cell. Okay, then we have another protein called P24, which is known as core protein, right? Core protein. This is part of the core of the virus, right? Okay, and when you look into the core of the virus, we have the RNA there, and we have two or three important enzymes involved in RNA metabolism. The first one is reverse transcriptase. So what reverse transcriptase does? It helps virus to produce DNA molecules from its RNA templates, right? That is very, very important, because once the virus infects a human cell, it has to use human cell to produce the proteins required for it and also to produce the genetic material of it, right? So in human cell, it has to integrate with human genome. So for that, it has to get converted into DNA, right? RNA cannot just get attached with DNA. It has to get converted to DNA. RNA has to get converted to DNA. This is done by our reverse transcriptase, right? Then once the virus has entered the human cell, that is typically CD4 cell, right? It starts replicating. It starts producing its own particles, right? So it produces its genetic material. It produces the proteins required for it, its structural proteins and its enzymatic proteins or functional proteins, as you like to call it. Now all of them needs to be assembled. So these proteins are often produced as large polymeric proteins. They need to be cleaved and assembled to form a viral particle, and then they should be released into surrounding to infect other set of cells, right? So this cleavage of this large polymeric proteins to the individual proteins is done by an enzyme called as protease, right? So all of these are important targets for us when we talk about pharmacotherapy of HIV infection, right? Protease inhibitors, reverse transcriptase inhibitors. Then this GP120 is fusing with our CD4 receptor, so we can try to block at that point of level, right? So all of these are our targets for pharmacotherapy, right? This is a basic structure of HIV virus. Now, having understood this structure, let us talk about the viral replication cycle. So imagine you have a patient who got exposed to a positive person through one of the known modes of transmission, maybe blood transfusion, needle prick, or IV drug abuse, or through sexual contact. Now these viruses have made entry to this person's body. Like, what is the principal cell that these viruses are going to affect? We all know the cell that these viruses are going to affect is CD4 cells, right? So viral particles, HIV viral particles, have to go and bind the CD4 cells. So they bind the CD4 cells on a receptor called as CD4 receptor, right? CD4 receptor. What is the binding structure from the viral side? Like we have the spike protein for COVID. Here it is GP120, right? Here it is GP120. So this GP120 has to go and bind the CD4 receptor. So here we can see the CD4 receptor. This GP120 should come and bind this CD4 receptor. That is the first step. Once GP120 gets anchored to CD4 receptors, now the next important step is it has to recruit another receptor. So just merely binding to the CD4 receptor is not adequate. It has to recruit another receptor called as co-receptors, right? Co-receptors. This is the next important step. There are two types of co-receptors. One is CCR5, the other one is CXCR4. Okay, there are two types of co-receptors. Most of the viruses in the initial phase, when they first infect, they usually use CCR5 as their co-receptors. Later they get transformed to a phenotype where they start using CXCR4 as their co-receptors. Like once they have infected human tissues and they have done multiple cycles of replication, right? In that case, they start using this CXCR4 as their co-receptor. The primary co-receptor is always CCR5, right? During the first infection, it is CCR5. Okay, so once the co-receptors are recruited, the CD4 cell, CD4 receptor, HIV virus, GP120 comes and binds to the CD4 receptor. Co-receptors are now recruited, right? Once the co-receptors are recruited, the next major change happens is with respect to the viral cell. Viral cell undergoes some kind of conformational change so that it kind of fuses with the host cell and injects its genetic material into the host cell, right? So these are the major chain of events that are occurring during initial infection, right? So this is a flow of image that clearly gives you an idea, right? So this is a typical viral membrane and it's GP120, GP41, right? Now this is getting attached to CD4 receptor, right? So this green thing is the CD4 receptor, right? So once the GP120 gets attached to CD4 receptor, there is recruitment of these co-receptors called as CCR5, right? The initial infection cycle, it is CCR5. Subsequently, after multiple cycles of replication, it is CXCR4, right? Okay, CCR5. Once that gets included, right? Once that gets recruited, what we see here, we are seeing a form of conformational change in the viral particle. So this conformational change is making sure that viral particle now gets fused with the host cell, right? Fused with the host cell. Once this fusion occurs, now virus can inject its genetic material into the host cell, that is CD4 cell, right? Okay, so these are the initial events. Now once the viral RNA is inside the host cell, it is RNA, right? So it has to replicate and convert, right? Not replicate, I should say. The RNA should get converted into DNA, right? So once it is inside the host cell, HIV RNA gets converted into HIV DNA. So this conversion is brought about by an enzyme called as reverse transcriptase, right? So reverse transcriptase converts HIV RNA to HIV DNA, right? So this is the first step inside the CD4 cell. Once it is converted to DNA, now this DNA has to go and get integrated into host DNA, right? Host genome. So that is CD4 cell DNA. So this integration, right? The HIV DNA getting integrated with the host DNA, this integration is facilitated by an enzyme called as integrase, right? Integrase facilitates this integration of HIV DNA to the host cell DNA. Okay, once its DNA makes its way into host cell DNA, just like how the host cell multiplies, host cell is able to do its metabolic functions, HIV DNA also can start doing its work, right? So this HIV DNA will now start producing its genetic material, that is RNA, and it will also start producing important proteins, structural and non-structural proteins required for formation of viral particles, right? All these viral particles finally need to be assembled and then discharged from the cell to infect subsequent cells, right? So these HIV proteins are usually produced in the form of large proteins. So those large proteins need to be cleaved. So this cleaving or this cutting is done by an enzyme called as protease, right? Protease. HIV protease, and after that viral particles are assembled at the cell membrane, and these viral particles are now released from the infected cell by a process known as budding. What is budding? You have a plasma membrane of this CD4 cell. There is a viral particle which is formed. When it is coming out, right, it is taking away a little bit of its host cell membrane, right? So it will be like popping out. This cell membrane will be popping out like this. There will be a viral particle here, right? There will be a viral particle, and eventually when this viral particle is released, the cell membrane is ruptured, leaving behind a leaky cell membrane, right? Clear? Now once a CD4 cell is infected, right, this viral genetic material uses the CD4 cell for formation of hundreds of its own copies, right? So when hundreds of such cells are making an exit, hundreds of viral particles are making an exit from the CD4 cell, right, it is leaving behind multiple areas of injured plasma membrane, right? Injured cell membrane of the CD4 cell. So this CD4 will not be able to survive this attack, right? So it is leaking the cytoplasm everywhere, and eventually the CD4 cell dies. That is why we have a decrease in CD4 count in HIV infected individuals. Clear? Okay. So now we know the whole cycle of HIV replication. Now just a quick look at the potential targets for treatment of HIV. Okay, so first we were talking about this GP120 getting attached to CD4 receptors. Can we do something to prevent this attachment itself? Yes, we can do. We have developed a monoclonal antibody called as ibalizumab, right? So I am talking about a monoclonal antibody called as ibalizumab. What ibalizumab does? Ibalizumab is a monoclonal antibody against CD4 receptors, right? It is a monoclonal antibody against CD4 receptor. So it can prevent the binding of these viral particles to the CD4 receptors. Clear? Okay. After this, okay, can we do something? Like in this image we saw ibalizumab, it can prevent CD4 binding. Okay. After that, can we stop if we are not treating the patient with ibalizumab, right? So can we stop this GP120 binding the CD4 receptor, this whole thing trying to recruit the CCR5? Can we prevent that from occurring? Yes, we can prevent co-receptor binding using drugs such as maraviroc, right? Maraviroc, right? Okay, maraviroc. This is called as an entry inhibitor. These are called as an entry inhibitor, right? So these are basically preventing the recruitment of the co-receptors, right? Ibalizumab can also be called as an entry inhibitor because it is preventing the binding of your viral particle to the CD4 receptor. Okay. Now, if you are not using maraviroc or other newer drugs which are primarily preventing co-receptor binding, in the next step, can we do something like your viral particle has attached to the CD4 receptor, then it has recruited the co-receptor. After that, what is the next change? Fusion, right? So can we inhibit this fusion from occurring? Yes, we have developed drugs called as fusion inhibitors. Called example is enfuvirtide, right? This is a classical example for a fusion inhibitor, right? Fusion inhibitor. So this is what we can do in the initial phase of its replication. Now, if the cell has made its entry, if the viral cell has made its entry into the host cell, can we do something to prevent further progression or further replication? Yes, in that case, we try targeting these viral proteins, right? What are the proteins? The first thing we talk about is reverse transcriptase inhibitors, the backbone of HIV treatment as of now, right? So we can inhibit this reverse transcriptase activity, right? That is one thing we can do. The second thing we can do is we can try to inhibit this integrase enzyme, right? So if you're not stopping reverse transcriptase, like mostly we treat the patients with combination therapy, I do agree. I'm just giving you a conceptual understanding, right? So if you have not stopped the viral entry into the cell, viral RNA has made its way into the host cell, right? And you're not preventing this RNA to get converted into DNA. Then once it gets converted into DNA and gets integrated into host genome, that is an irreversible step, right? It is a irreversible step. That means once that occurs, the host cell is infected for life. This CD4 cell will die, but it will not get rid of this viral DNA, right? And if it allows its machinery to be used for replication, then a whole lot of other CD4 cells will get infected with HIV, right? So we can try inhibiting this integration also, right? So this integration inhibitor is like a classical example for integrase inhibitors are our dolutegravir, right, which is like the standard drug used in NACO regimen today, right? Dolutegravir. And your reverse transcriptase inhibitors, the standard drugs that are used in our NACO regimens are your TDF, tenofovir, disoproxil fumarate, and your 3-TC or lamivudine, right? These are classical examples for reverse transcriptase inhibitors, and they are the standard components of the current NACO regimen, right? Dolutegravir is also a standard component. So we are trying to do two things here, right? We are trying to suppress this reverse transcriptase so that the viral DNA is not formed, and whatever DNA that is formed, we don't want it to integrate with the host cells, right? The primarily infected cells, yes, it will be able to integrate, but after this, even if the particles are formed and they're released into circulation, the other CD4 cells, it will not be able to integrate with their genome, right? So that is dolutegravir. Okay. After that, now at the level of assembly of these viral particles, can we do something? Yes, we have this enzyme protease, right? So we can try targeting this protease. So we can use the protease inhibitors, right? What are the protease inhibitors we know? Okay, one example, lopinavir, right? Lopinavir, ritonavir, right? These are all protease inhibitor examples. Clear? Okay, so this is just a quick look at the pharmacology. Now let us talk about some of these drugs. Okay, now the Reverse transcriptase inhibitors, particularly the most commonly used regimen worldwide right now includes emtricitabine. It is a very effective drug. But India's regimen, the NACO regimen, mainly uses tenofovir, TDF form and lamivudine, right? So most other regimens use tenofovir plus emtricitabine combination, but in India, maybe cost concern, we use a combination of lamivudine plus tenofovir in our NACO first line regimen. Okay. Now I want you to remember one particular point, which is a MCQ point with respect to reverse transcriptase inhibitors, that is abacavir. What is the point I'm talking about? Whenever we talk about abacavir, we should keep in mind about HLA B5701. Okay. Why is this important? Because this HLA variant is associated with increased risk of Stevens-Johnson syndrome if patient is treated with Stevens-Johnson syndrome or toxic epidermal necrolysis if patient is treated with abacavir, right? So it is now considered as an acceptable practice to do HLA B5701 assay before you start patient on abacavir. Okay, clear? Okay. Now we have other set of drugs like your protease inhibitors. Protease inhibitors, currently most commonly used drugs are your lopinavir, ritonavir. Often we use the ritonavir boosted lopinavir, but we can also use azatanavir or darunavir. Okay. Then in terms of integrase inhibitors, we have the most commonly used drug in India is dolutegravir, part of our NACO regimen. Then we can also use raltegravir or elvitegravir. Okay. The CCR5 inhibitor, that is maraviroc, right? We have already discussed about it, maraviroc. Then other fusion inhibitor that this list is not talking about, that is enfuvirtide. Not routinely used these days, that's why this list is not talking about enfuvirtide. Okay. Now this list also talks about a drug which some of you may not be very familiar with, that is cobicistat, right? What is cobicistat? Cobicistat is an inhibitor of, cytochrome P450 3A. It is an inhibitor of 3A. So if you're treating someone with drugs which are predominantly metabolized by this cytochrome P453A, by inhibiting this, you can make those anti-HIV drugs bioavailability increase, right? So what are the drugs? Those drugs are basically our protease inhibitors, azatanavir and darunavir, right? So when you're treating someone with azatanavir, right, or darunavir, you can co-prescribe them with cobicistat, right, azatanavir or darunavir. Clear? Okay. This is one more MCQ that can be asked from the pharmacology side. Okay. So one thing this is not talking about, this list is not talking about, is ibalizumab, right? Ibalizumab is the first monoclonal antibody approved by FDA for treatment of HIV, and this is the first IV drug available for treatment of HIV, right? This is a monoclonal antibody against CD4 receptor. Clear? Okay. So these are the important pharmacological options we have. Okay. So we were talking about this HIV per se. So let us talk about host immune response. So far we have spoken about HIV particle getting attached to CD4 cell and making its way into CD4 cell and starting to replicate there, right? And once one cell is affected, it will produce hundreds of copies, and those hundreds of copies will get distributed to various other CD4 cells. So the infection now starts spreading. Can host body keep quiet? No, it has to mount an immune response, right? So what is the immune response host body would be mounting? That would be the initial immune response to HIV is cell mediated immunity, right? So initial response is cell mediated immunity. So that means more and more CD4 cells will be assigned to attack the viral particles. Eventually they will get infected. It is like they are on a suicide mission, right? So initial response will be increase in CD4 count, right? So CD4 cells are the initial responders. CD4 T cells are the initial responders. Eventually the humoral immunity will kick in, right? Eventually the humoral immunity will kick in, and then there will be formation of HIV specific antibodies, right? HIV specific antibodies. Once the HIV specific antibodies come into picture, most of the patients, the HIV viral load starts coming down, at least initially, right? Not all the patients infected with HIV will become AIDS the next day, right? So initially, at least for some time, our humoral immunity will be able to keep the HIV viral load under check, right? So I hope the point is clear. Initial response is in the form of CD4 cells. Now, what is going to happen to these CD4 cells which are now trying to attack the viral particles? These CD4 cells, as I've told, they are on the suicidal mission. So the CD4 cells will get infected with HIV particles, right? And HIV particles start using these CD4 cells for their multiplication. So HIV starts multiplying in the CD4 cells. So once the HIV viruses are released through budding, that causes increased T cell permeability, right? So these CD4 cells will eventually die because of that. That is why we have a decreased CD4 count, right? So once we have a acute HIV infection, right, after that your CD4 count can to some extent decreases significantly during your acute HIV infection, and after that it might rise to some extent, can get a plateaued, but from there it can keep decreasing, or it can remain plateaued for some time. Eventually it will start declining, and then patient will start heading towards AIDS, right? Okay. Now this is one point I want you to note. I have already discussed that initially virus behaves as a R5 phenotype. That means it uses CCR5 as its co-receptor, right? Co-receptor. But eventually all these CCR5 phenotypes get transformed into CXCR4, what we call as X4 phenotype, right? Because when they are making an entry, they want to use this CCR5 as the co-receptor. But once they have gained an entry into the human body, right, now the challenge is not about entry, the challenge is about infecting more and more cells, right? So for that they get transformed into CXCR4 variant, right? Okay. So this is about the fate of CD4 cells. The CD4 cells will try to attack HIV particles, but indeed they are on a suicide mission. They die, CD4 count decreases, right? Okay. Now what is going to be our humoral response? Initial CD4 cell counts, eventually humoral immune system has to pitch in by formation of antibodies. So a humoral response starts becoming evident, or antibodies become evident between, on an average, 3 to 6 weeks after initial HIV infection. It can go up to 3 months, but on an average it is around 3 to 6 weeks. So during this period the antibodies become detectable, and as the antibody titer increases, right, viral loads keeps decreasing, right? So this graph gives you a whole idea about the HIV infection. So in this graph you see this pink graph. The pink graph is about HIV RNA load, and this blue graph is about CD4 lymphocyte count, right? So here is a patient who had, say, an acute infection here, right, somewhere at the 0 day. Now 3 weeks later, that is where I said roughly antibodies start becoming evident, right? So once the patient got infected, right, the HIV particles start replicating, right? HIV particles start replicating. It starts peaking up, right? It is peaking at maximum. At this point of time, the CD4 cells are being destroyed because they are being used up, right? Uska istemal ho raha hai. So CD4 counts keeps decreasing. So somewhere at the peak of this viral load, some of the patients can develop what is called as acute HIV syndrome, right? Acute HIV syndrome. I'll talk more about it in a bit, but right now just remember, some of these patients can have acute HIV syndrome, need not be seen in all patients, right? Okay. So viral load increase now, CD4 count decrease. So at one point viral load is at its peak, CD4 count is at its lowest, right? But by this time, roughly at around 3 to 6 weeks time, the humoral immunity kicks in, antibodies start getting produced, so your viral load starts coming down, right? So at least initially humoral immunity is capable of clearing the viral infection. So viral load starts coming down, and as your viral load starts coming down, your CD4 count starts improving, right? CD4 count starts improving, and we reach a point where your CD4 count is plateaued, your viral load is plateaued, and patient reaches a latent stage, right? Patient might persist in this latent stage for many years, right? So some of the patients rapidly progress to develop AIDS. Some patients slowly progress. So that depends on various factors. We will be discussing that also, right? So now the CD4 count has reached its some value, right? Then over the years later, from the clinical latency stage, viral replication starts increasing again. So the viral load starts rising, and as the viral load starts rising, your CD4 cell count starts dropping down. Okay, now the CD4 count has reached its plateau stage. Your viral load has reached its plateau stage. Patient might remain in the latent stage for some time. It is usually 7 to 8 years at least. But as I've already told you, some can have a rapid progression, some can have a slow progression. But eventually what happens is this viral DNA, which is now part of the integral part of human genome, eventually will start producing more and more RNA particles, right? And with more and more HIV viral particles being formed, more and more CD4 cells will be destroyed. So again, at some point, CD4 cell starts declining, your RNA viral load starts increasing, and because of your decreasing CD4 count, you become vulnerable to develop opportunistic infections, and either HIV related direct complications or these opportunistic infections will knock you down, right? So that is the usual story of patients infected with HIV. Clear? Okay. Now, let us talk about the natural course of HIV infection. We have understood the basic pathophysiological process. Now, let us talk about the natural course. As I've already told you, after HIV infection, with an incubation period of around 3 to 6 weeks, sorry, not 3 to 6 weeks, roughly 3 to 4 weeks, right? After an initial incubation period of 3 to 4 weeks, patients can present with what is known as acute HIV syndrome. As I've already told you, all patients need not present with acute HIV syndrome. It is around 50% of the patients present with acute HIV syndrome. So what is this acute HIV syndrome? It is an acute febrile illness which clinically resembles infectious mononucleosis. So these patients present with acute febrile illness, acute fever, pharyngitis or sore throat, throat pain, cervical lymphadenopathy, and a maculopapular rash. So clinically, it resembles infectious mononucleosis, right? In simple words, you can say acute HIV syndrome is a mimicker, or it is very similar to infectious mononucleosis that usually occurs roughly at around 3 weeks after patient getting exposed or infected with HIV. Right? No case of acute HIV syndrome usually appears after 4 weeks. Most of the cases appear, if they are appearing, within 3 to 4 weeks. Right? Now this usually occurs within 3 to 4 weeks, rarely ever after 4 weeks. So during acute HIV syndrome, as we all know, viral replication is at its peak, so the CD4 count is at its lowest, right? Now at this point of time, there are only two ways of diagnosis of HIV infection. Either clinical, once you suspect, you can check for P24 assay. It may be detectable by this time because it is usually taking 2 to 3 weeks after the infection, right? So first 11 days is what is called as eclipse period. After HIV infection, first 11 days is called as eclipse period. During this point, nothing can detect HIV infection, neither your RNA PCR nor your P24 assay. But after your 11th day, your RNA PCR can become positive, and around 16th to 17th day, your P24 assay can become positive. So majority of the patients who having acute HIV syndrome will be positive for RNA PCR. You will be able to detect HIV. You will be able to detect P24, right? So P24 will be detectable. PCR will be positive at the time of acute HIV syndrome in most of the patients. Can we detect antibodies at this point of time? Mostly no, right? Once antibodies start appearing, the viral load start coming down. By that time, the patient would have shown recovery from acute HIV syndrome. So most patients who are presenting with acute HIV syndrome, we don't have detectable antibodies. But the time they are making recovery, antibodies will be evident, right? So antibodies usually appear 3 to 6 weeks after initial infection, right? So patient present with acute HIV syndrome, after that antibodies start appearing, right? Okay, clinically, as we have already discussed, this is an infectious mononucleosis like illness. Okay, now I want you to remember one particular point about acute HIV syndrome. What is that point? Acute HIV syndrome, right? Presentation with an acute rashy febrile illness is associated with acute HIV syndrome is associated with increased risk of progression. Increased risk, also the rapidity of progression, increased and rapid progression to AIDS, increased risk of progression to AIDS. So in comparison to someone who got infected with HIV virus but did not develop acute HIV syndrome, he has a lesser risk of progressing to AIDS, or in other words, he will progress towards AIDS much more slower in comparison to someone who got an acute HIV syndrome, right? So half of the patients who got HIV syndrome, acute HIV syndrome, they're more likely to progress faster towards the AIDS stage, right? This is one important true statement that you have to remember because it appears in MCQs. This has appeared also in MCQs, right? Okay. Now that was about acute HIV syndrome. So what next? After the acute HIV syndrome, patient is making a recovery. His CD4 count is recovering. Antibodies have appeared and viral load is decreasing. So patient achieves a plateau CD4 count. Patient achieves a plateau viral load. And then at this point of time, he is entering a chronic phase, right? Or in other words, a latent phase. So at this point of time, your CD4 count and your viral RNA remains in a plateau stage for some years, and after that your viral replication starts again. So your viral load starts rising, your CD4 count starts decreasing, and then you start heading towards AIDS, right? Now this transition from acute HIV syndrome to AIDS or chronic phase to AIDS is kind of unpredictable, in the sense in some patients it is very slow. Like some of the patients who have been HIV positive, they live their entire normal lifespan with minimal opportunistic infections, at minimal consequences of HIV infections, without even progressing to AIDS. Some of them succumb to the natural illnesses particularly relevant for that age. But then we also know some patients who very rapidly progress towards AIDS, right? So usually we say that it is at least going to take 7 to 8 years time in untreated patients to get into a stage of AIDS. But some patients can progress much faster. So we have a set of patients who can be called as rapid progressors, and we have a set of patients who can be called as elite controllers or rapid non-progressors. Right? We can call them as non-progressors, right? Rapid progressors, non-progressors, and elite controllers. Now, what are the characteristics of these patients? What we know so far, right? Like, do we know anything about why this particular set of patients progress rapidly, why this particular set of patients do not progress rapidly? Yes. In last 1 decade, we have understood some key points about it. Okay. So, what are the key points we have understood? The key points we have understood is the concept of viral set point. So, we are talking about this acute HIV syndrome and then viral load coming down, CD4 count recovery. So, at some point of time, this viral load achieves a plateau stage, right? This viral load at the plateau stage determines your risk of progression to AIDS. Higher the plateau stage viral load, rapid is the AIDS development. Lower the plateau stage viral load, slower is the development of AIDS, right? So this plateau stage viral load is what is called as set point viral load. So you can just look at this one thick line image, right? So patient's viremia peak at this point of time, patient might have developed acute HIV syndrome. Might, because only 50% patients develop, remaining 50% don't. But we know that patients who developed acute HIV syndrome have a higher risk of progression to AIDS, right? So this patient might have developed. Now from there, the viral load is coming down and it is achieving a plateau state here, right? So after that, it is going to remain at this level for some time, right? So this point determines the risk of progression to AIDS. Higher it is, higher the risk of progression to AIDS, rapid the risk of progression to AIDS. Lower it is, lower the risk of progression to AIDS, right? So those who are able to get their viral load to a very low value, right, often at undetectable value, are the ones who have the extreme slow progression. We call them as elite controllers or non-progressors, right? We have understood some genetic characteristics of these patients. What is that? Patients with HLA-B5701 and HLA-B2705, they are at very low risk of developing AIDS, right? The slow progressors usually positive for HLA-B5701 or 2705. Okay, and having HLA-B35 variant is associated with the risk of rapid progression. We call these patients as rapid progressors. Clear? Now, these are very important MCQ points, right? Which one of the following HLA variant is associated with harm or increased risk to progression to AIDS? That is HLA-B35, right? Which of the following HLA variants are associated with, or which of the following HLA variants confer protection against the progression to AIDS? HLA-B5701, HLA-B2705, right? Okay, before we move on, where else we spoke about HLA-B7501? Yes, we spoke about this variant when we spoke about abacavir, right? Now, this HLA variant protects you from having a rapidly progressing HIV infection, but it also increases your risk of developing abacavir-induced Stevens-Johnson's syndrome, right? Stevens-Johnson's syndrome. Good, clear? Okay. Now, if you have to understand like patient's risk of developing AIDS, when is the ideal time to do his viral load? Is it during his acute viral infection? Definitely no, right? At that point, then it will be at the peak. Now we want to know the set point, right? So we should know that majority of the patients reach their set point 6 months to 12 months after their index infection, right? After their first infection, 6 months to 12 months later, they reach this viral set point. So if you ask me, when do you want to do the viral load? I would prefer to do the viral load at the end of 12 months. At this point of time, definitely it will be at the viral set point low, right? So this will tell me whether my patient has high risk of progression to AIDS, rapid progression to AIDS, or low risk of progression to AIDS. Clear? Okay, so this is the concept of viral set point I wanted you to understand. Okay, now let us just take a quick journey through some images of acute HIV syndrome. So this is a patient of acute HIV syndrome. So what we have learned about acute HIV syndrome so far, 50% patients develop. It is typical infectious mononucleosis like illness. So these patients have pharyngitis, right? Pharyngitis, cervical lymph nodes, they have fever, and they have rash, right? So this rash is usually maculopapular. This rash is what you can clearly appreciate in this image, right? Okay. Now, when someone presents with acute HIV syndrome, I did use one particular word, right? What did I use? I used the word eclipse period, right? Eclipse period that lasts for around 11 days after initial HIV infection. At this point of time, PCR is negative and your P24 is also negative, right? Nothing can be detected, like it is eclipsed out, right? So where this terminology comes from? This terminology comes from a staging system which stages the progression of acute HIV syndrome, right? So what is the name of the staging system? The name of the staging system is 5-big staging system. 5-big, not big, 5-big staging system, right? This is also an MCQ that has been asked in the past. Okay, so we have to also learn some key points about 5-big staging system. So according to this, there is an eclipse period after acute infection with HIV, and then after that there are 6 stages of progression of acute HIV syndrome before it reaches what we call as the latent phase, right? So what are those stages? The first one is eclipse phase. Everything is negative, all eclipsed out. That lasts for around initial 11 days. RNA virus is replicating at this point of time, but the RNA has not reached a threshold which can be detected by our current generation of PCR assays, right? So your RNA is going to be negative, your P24 antigen is going to be negative, your enzyme immunoassay trying to identify the antibodies, anti-HIV antibodies, HIV specific antibodies will be negative, and this Western blot trying to assess the viral proteins, that will be negative, right? Everything is negative in the eclipse period. So from there we get into the first stage of first 5-big stage that lasts for around 5 days, right? So I think I did make a statement there, right? I said that your P24 assay usually becomes detectable after 16 days. I had already made this statement, right? So that means P24 assay is going to be negative in stage 1 because it is going to be detectable after 16 days. So 11 days eclipse period, then stage 1, that is for 5 days. So after 16 days, patients enter stage 2, that is where your P24 will be detectable, right? So only thing that is detectable in stage 1 is our RNA PCR, right? So our RNA PCR is the only thing that can identify HIV infection at this point of time. This whole 5-week stage is very easy to remember, right? We're talking about 4 things here. We're talking about HIV RNA, we're talking about P24 antigen, we're talking about ELISA or EIA, and we're talking about Western blot, right? 4 things. In eclipse phase, all are going to be negative. In stage 1, one thing will be positive, that is our RNA PCR, right? So in stage 2, 2 things will be positive, right? Stage 2 is after first 16 days, right? That is where our P24 becomes detectable. Our RNA PCR probes are much more effective in identification, so they will be able to identify little before. P24 becomes identifiable little afterwards, right? So now P24 is also positive. So in 5-big stage 2, we have 2 things positive, that is your HIV RNA and P24 antigen. This also lasts for around 5 to 5.5 days, right? So 2 things positive in stage 2. In stage 3, we have 3 things positive, right? What are those? Our RNA remains detectable or positive. P24 antigen remains positive, right? By this time, we are talking about a patient who is making his entry into roughly 3rd week, right? 3rd week post. 11 days, 5 days, that is 16 days, another 5 days, right? It's almost 21, 22 days. So at this point of time, most of the patients will have some evidence of antibody formation, right? So in 5-big stage 3, your antibody becomes positive, that is usually IgM antibody that we are talking about. So IgM antibody starts becoming positive in 5-big stage 3. So 3 things positive in stage 3: PCR, our P24 assay, and your antibodies, right? Okay, but your Western blot is going to be negative for any HIV specific bands. Okay, clear? Now in stage 4, 4 things become positive. So this stage 4 lasts for around 5.6 days. Roughly you can say 5 days, right? So at this point of thing, 4 things are going to be positive. So your RNA will be positive, your P24 will be positive, your antibody on enzyme immunoassay will be positive, and Western blot will start showing some activity in the form of, like, you have HIV specific bands, but those bands do not satisfy the preset criteria to call it as reactive or positive, but you see some activity there, right? So your Western blot starts showing some activity. So that is our stage 4, right? So when do we call as Western blot positive? We will call it as Western blot positive if, according to US FDA, it will be called as positive for HIV if 2 of the 3 bands are positive. What are the 3 bands? One is for P24, the other one is for GP41, right? I'm not talking about the conventional P24 assay. We're talking about Western blot. P24, GP41 and GP120, 160. Out of these 3, if 2 bands are positive, then it will be declared as reactive, right? So in stage 4, it will not satisfy this criteria, but one band may be positive. So it is an indeterminate pattern, but some activity is what we are saying. So we are talking about 4 elements there. Okay. Now in stage 5, which lasts for many years, like around 3 months, at this point of time, our RNA remains positive, because once the viral DNA has been integrated into host cells, there will be some low grade replicative activity going on, and RNA will be identifiable in most patients, right? So rarely, particularly those slow progressors that we are talking about, right, elite controllers, yeah, in those patients RNA may go to an undetectable level. Otherwise, on a normal person, RNA remains detectable, right? But your P24 antigen may become non-detectable at this point of time, because the immune system will inhibit the replication to some extent, that the P24 is not detectable, at least in some set of patients, right? So P24 in stage 5 may be plus minus. Your enzyme immunoassay antibodies are formed and they remain positive, right? Enzyme immunoassay remains positive. At this point of time, there may be IgG antibodies being formed, right? And if you look at the Western blot, it is this phase where it particularly becomes clearly reactive. It satisfies this US FDA approval, right? US FDA method. 2 out of these 3 bands for P24, GP41 and GP120, okay, 2 out of these 3 becomes positive. It becomes reactive in 5 big stage 5, right? But even now, it will be absent for P31, right? It will be absent for P31. It becomes positive for P31 in stage 6, right? It becomes positive for P31 in stage 6. The rest of the things are going to be same in case of stage 6, but P31 also becomes positive. So we call it as an open-ended, like we have reached the 6th stage. After this, the 6th stage persists as long as patient persists, right? Okay, open-ended. There is no end till the patient exists for the 6th stage. These are the 5 big stages, right? Clear? Okay, so having understood this, now let us talk about the chronic phase. So we have spoken about acute HIV infection, its 5 big stages. We have also spoken about immune response, right? We have seen an image of the HIV rash. Now it is time for us to talk about the chronic phase of HIV infection. So what is happening in the chronic phase? In the chronic phase, viruses are like retreating from other sites, and they are finding a shelter mainly in the gut associated lymphoid tissue. That is the shelter. As long as they're going to remain in the latent phase, this is the primary shelter for HIV viruses, right? So from this point, they start replicating. Virus starts multiplying in gut associated lymphoid tissue, and from there they can start disseminating to the other sites, right? Once they start disseminating to the other site, what is going to happen? CD4 cells are their primary targets. So CD4 cells will start going down again, and your CD4 CD8 ratio gets reversed or flipped. Okay, so this is the chronic phase. We have already discussed the viral set point. So in the chronic phase, patients might, depending on the CD4 count, they may be vulnerable for some HIV systemic involvement, right? It definitely depends on the viral, definitely depends on the CD4 count per se, because most of the HIV manifestations at this point are related to host immune system. If the host immune system has become weak now, then they are vulnerable for opportunistic infections. If it is holding on well, then they are less vulnerable for opportunistic infection, right? So MCQ wise, they might ask you at what CD4 count, what particular opportunistic infection is much more common, right? We'll talk about the systemic involvement in detail later, but right now just address this one table, which is like a standard template for MCQs. When CD4 count is more than 500, mostly the risk of opportunistic infection is negligible or comparable to normal person. At this point of time, when the CD4 count is more than 500, even if it is an HIV infected person, mostly we will be seeing them having this generalized lymphadenopathy, right? Generalized lymphadenopathy may occur with CD4 count 500 plus. Other than that, we may not have any major stigmata of HIV infection, right? But once the CD4 count starts coming down below 500, we start seeing stigmata of HIV infection. So at CD4 count less than 500, tuberculosis risk becomes increased, particularly when you're talking about countries where the tuberculosis is endemic, because a reasonable number of patients might have what we call as latent tuberculosis, right? Once the CD4 count goes down, the latent tuberculosis can get activated, right? Latent TB. Then oropharyngeal candidiasis. Okay, oropharyngeal candidiasis becomes evident at much higher CD4 count. Esophageal candidiasis, much lower CD4 count, right? Oropharyngeal candidiasis, CD4 count less than 500. Esophageal candidiasis, CD4 count less than 200. So we use esophageal candidiasis as a AIDS defining illness or WHO stage 4 HIV, right? Okay. Then HIV patients are at increased risk of developing Kaposi sarcoma due to HHV8 infection. They are also at increased risk of developing non-Hodgkin's lymphoma. They can appear at much higher CD4 count, above 200, right? Below 500 and above 200. Now, when the CD4 count is less than 200, that is where the real opportunistic infection starts becoming evident. So, patients can develop pneumocystis carinii pneumonia, or current terminology, pneumocystis jirovecii pneumonia. They can develop chronic herpes simplex ulcers. They can develop esophageal candidiasis. They can develop GIT infection by Isospora belli. They can have this thing called as HIV wasting syndrome, where patient is having significant weight loss, more than 10% weight loss, associated with diarrhea and fever, all of them lasting for more than 1 month. We call it as HIV wasting syndrome. Yeah, I think this is point you need to remember. HIV wasting syndrome. HIV wasting syndrome is, according to WHO, it is a stage 4 HIV infection. It can be considered as an AIDS defining illness, right? So what is happening here? Patient is losing weight loss unintentional more than 10%, right? Plus diarrhea for more than 1 month, right? Plus fever for more than 1 month. This is what we call as HIV wasting syndrome. So just weight loss more than 10% is a stage 3 according to WHO HIV staging, and stage 4 is where we have a HIV wasting syndrome, right? This is akin to or equivalent to AIDS defining illness, right? Okay, now HIV associated dementia, especially the milder form of it, start becoming evident once the CD4 count is less than 200. Once the CD4 count further goes down, it goes down below 100, right? At this point of time, cerebral toxoplasmosis risk increases, cryptococcal meningitis risk increases, cryptosporidiasis risk increases. Some books mention 300 also for cryptosporidiasis, but I think this table is the one which we should be going with. Cryptococcal meningitis, cryptosporidosis, microsporidiasis, cytomegalovirus infection. Okay, cytomegalovirus infection also, I particularly wanted to remember that it becomes much more profoundly evident once the CD4 count is less than 50, right? It can become evident once it is less than 100, but it is much more profoundly evident once it is less than 50. At this point, particularly CMV retinitis is very common, right? So cytomegalovirus infection, then progressive multifocal leukoencephalopathy, another stage 4 condition, right? Another stage 4 condition according to WHO, progressive multifocal leukoencephalopathy. All of them are becoming evident once the CD4 count is less than 100. Finally, once the CD4 count is less than 50, at this point of time, two important things to remember, that is CMV infection, particularly CMV retinitis, right? And your Mycobacterium avium complex, MAC infections, and Toxoplasma gondii infections, right? So these are very common once the CD4 count is less than 50. Clear? Okay, so this is one table that you need to spend some time trying to memorize. Okay, so now let us talk about this individual system involvement, starting with the CVS. Okay, so HIV per se directly can affect the heart and its structures, right? That is in fact the most common presentation, but it can also indirectly affect the cardiac, right? HIV directly affecting the heart can cause coronary artery disease. HIV can affect the vessels, it can affect the myocardium, so there is increased risk of coronary artery disease. Apart from that, HIV is associated with increased atherosclerosis, right? So HIV is characterized by accelerated atherosclerosis, right? Apart from that, if you're treating HIV patients, particularly with protease inhibitors or some other drugs which are known to cause dyslipidemia, they are going to act as a contributor for development of atherosclerosis. But even if you're not using the drugs which are known to cause dyslipidemia, so HIV itself can cause dyslipidemia, but even if HIV is not causing dyslipidemia, there is accelerated atherogenesis. There is myocardial injury directly by the virus. All that put together increases the risk of coronary artery disease. So if there is an MCQ asking what is the most common cardiovascular manifestation of HIV infection, it is coronary artery disease. Okay. Apart from that, yes, myocarditis can occur. There is also an entity called as HIV associated cardiomyopathy, which is a dilated cardiomyopathy, right? So even in the absence of diabetes mellitus, if an HIV patient presents with the dilated chambers, you should be thinking of HIV associated dilated cardiomyopathy, right? Patients can develop pericardial effusions also, which are kind of common things to encounter, but pericarditis per se is very rare. So patients of HIV infection can have pericardial effusion without this classical evidence of pericarditis. That means like classical evidence of pericarditis in the sense patients having pericardial rub, having this classical pericarditis ECG images, that is a bit unusual, right? So there was an MCQ in one of the PGIMR exam which was asking which of the following cardiovascular manifestation of HIV is the least common to occur among the following, right? So pericarditis is the rarest among whatever we have spoken. Myocarditis is much more common, dilated cardiomyopathy is much more common, pericardial effusion are definitely much more common. The classical pericarditis is the rarest one. Clear? Okay. Now after the CVS, let us talk about the gastrointestinal tract involvement. What are the manifestations? Two things to note here. One is gastrointestinal tract is one of the very important organ which becomes vulnerable for opportunistic infection. The reason is like we keep eating and we keep exposing ourselves to pathogens. In an immunocompetent person, all those pathogens are tackled, but in HIV, they are not able to tackle, so they are becoming vulnerable for infection, right? So GIT, one thing is about infection, we will be talking about it. Plus, the second thing is there is also something called as HIV associated enteropathy. HIV enteropathy or HIV associated enteropathy. These two things we need to know about the GIT involvement in HIV, right? So what are the opportunistic infections? Cryptosporidiasis, right? Cryptosporidiasis, again, it can present in the form of chronic diarrhea lasting for a month or more than that, and it may be associated with malabsorption syndrome, right? Similarly, microsporidiosis caused by enterocytozoan bionici. There also patient can present with chronic diarrhea, may be associated with malabsorption, right? And this isospora belli infection, right? All of these can present with chronic diarrhea lasting for more than 1 month, right? An HIV patient having diarrhea lasting for more than 1 month, these are the infections that we will be suspecting first. MCQ wise, they might ask you what is the drug of choice for these three organisms. So if it is cryptosporidiosis, the drug of choice is nitazoxanide. Nitazoxanide may not be able to completely eliminate or clear the cryptosporidiosis, but at least it decreases shedding. Okay. Now, nitazoxanide, where else we have heard about it? Yes, right. We use nitazoxanide for two other conditions which are important for us to remember. We can use it for treatment of Giardia lamblia infection, right? Giardiasis, and we can also use it in treatment of H. pylori infection. Can you tell me what regimen I am talking about where nitazoxanide is used? Yes, the regimen is called as load regimen, right? It is called as load regimen. So there were questions about which of the following is not a component or is a component of load regimen, and very often students go for a wrong choice in that case, right? So the load regimen has levofloxacin, omeprazole and doxycycline, plus the A in load regimen is not amoxicillin. That is what the common mistake that most of us do. The A here stands for a brand name of the drug. The brand name is Alina. Alina is the brand name for nitazoxanide, right? So a very famous load regimen today uses nitazoxanide. So three indications for use of nitazoxanide, right? Cryptosporidiosis, then H. pylori infection as component of load regimen, and Giardia lamblia infection. Okay. The drug of choice for enterocytozoan bionici infection is albendazole, and the drug of choice for isospora belli infection is trimethoprim sulfamethoxazole or cotrimoxazole, right? Okay, this is about the opportunistic infection. Now talking about what we call as HIV enteropathy. What is HIV enteropathy? HIV enteropathy is a condition where patients are presented with diarrhea lasting for more than 1 month, or in other words, there is chronic diarrhea which is unexplainable by any other causes, right? Your extensive workup trying to find out opportunistic infections is negative. In that case, we will call it as HIV enteropathy. This definition is important. They can ask MCQ about it, right? Okay, so that is about the GIT involvement. Now coming to renal involvement. Renal involvement, yes, obviously there is increased risk of patient developing urinary tract infection. There is increased risk of pyelonephritis. But apart from that, HIV directly can cause a complication known as HIV associated nephropathy, what we call as HIVAN, right? 2 or 3 important MCQ points to note here. HIVAN histopathologically is characterized by focal segmental glomerulosclerosis, right? FSGS is a histopathological hallmark of HIV associated nephropathy. Now, in terms of epidemiological risk, it is the black race which is at increased risk of developing FSGS if they get infected with HIV in comparison to white race, right? So, blacks are at increased risk. Now, how these patients are going to present? HIV patient standing for some time, means like HIV positivity for some days, right, for some time, then developing FSGS. These patients will present in the form of proteinuria. Proteinuria is the hallmark of FSGS or HIVAN, right? And when we talk about this proteinuria, to start with, it may be in the subnephrotic range, but eventually it can go to nephrotic range, right? It can go to nephrotic range. To start with, it may be subnephrotic, but eventually it can progress to nephrotic range proteinuria. Okay. So how do we handle these patients? Yes, definitely we have to treat the HIV, try to control the viral load as much as possible, give a boost to CD4 count. But apart from that, using AC inhibitors can be helpful, right? We're talking about a condition where there is proteinuria, so using AC inhibitor starts making some sense there, and some studies have shown that it is beneficial. Similarly, low dose prednisolone may be beneficial, right? So this is one true statement I want you to remember. So AC inhibitors and low dose prednisolone may be beneficial in patients with HIV associated nephropathy. Clear? Okay. The next organ involvement we're talking about is skin, right? So in the last NEET SS examination, there was a question from this. So they had asked which of the following is the most common dermatological manifestation of HIV infection, and on some paper there was also an image based question, right? So the most common dermatological manifestation of HIV is seborrheic dermatitis. That is the most common, seen in more than 50% of the patients. And we have to note a particular point here. The severity of seborrheic dermatitis correlates with the CD4 count. Lower the CD4 count, much more severe will be the seborrheic dermatitis. So in other words, it correlates with the disease activity, right? So in India, if you are into infectious diseases practice, or if you are into general medicine practice where you have frequently encountering HIV patients, the moment patient walks into your OPD, you know that, okay, I am probably dealing with a case of HIV, looking at very, very severe seborrheic dermatitis. That is very much evident once the patient is walking into your OPD, right? Okay, so it correlates with CD4 count. This is one particular point I want you to remember. First point, it is the most common dermatological manifestation, and seborrheic dermatitis correlates with the CD4 count. Okay. The next thing is psoriasis. Okay, the point to note here is HIV doesn't increase your risk of developing psoriasis. So the incidence of psoriasis in HIV positive individuals and general population is comparable. The point I am bringing here is, if you are someone who is HIV positive and you develop psoriasis, then it is going to be much more profoundly severe, right? So psoriasis in HIV positive individuals is likely to be more severe in comparison to psoriasis occurring in non-HIV individuals, right? Okay. Then we all know this characteristic thing, right? Kaposis sarcoma, right? Kaposis sarcoma, we were talking about it. It can occur with the CD4 count above 200, below 500, right? And it is usually where patient is also co-positive for human herpes virus 8, right? So human herpes virus 8 is the one that is responsible for Kaposis sarcoma. This herpes virus 8 infection becomes much more likely when you have HIV, right? So this is about the dermatological manifestation. Okay, now this is the image which exact image, actually this is the exact image which appeared in the NEET examination. Most of the students said that this is the image that they had picked up, and this is the internet downloaded image. So here we can clearly appreciate the seborrheic dermatitis, right? Okay, now coming to the neurological manifestations of HIV. What are the neurological manifestations? The neurological manifestations of HIV include the classical opportunistic infections, right? Those individual opportunistic infections we have discussed in the infectious disease module, so I would recommend you to go through them, right? So like toxoplasmosis, right? CNS toxoplasma infection, then cryptococcal meningitis, then progressive multifocal leukoencephalopathy. Yes, all of them are important, and we have addressed those in reasonable details in different video modules. So today I will not be talking about the opportunistic infection. Apart from that, what else we see in the CNS because of HIV infection? So patients with HIV infection are at increased risk of developing peripheral neuropathy, right? So what kind of peripheral neuropathy we see? Peripheral neuropathy can be of three types in patients with HIV infection. One is inflammatory demyelinating polyneuropathy, what we call as CIDP, right? So today HIV is an important cause for chronic inflammatory demyelinating polyneuropathy, CIDP. For CIDP, HIV today is a very, very important cause, right? Then the second thing we can see is distal sensory polyneuropathy. Again, please pay attention to wording. I'm talking about distal sensory. I'm not adding the word motor. Motor neuropathy is rare in patients with HIV infection. Distal sensory polyneuropathy, followed by sensory motor. Motor isolated, so not routinely known to occur, right? So this is the most common thing. Distal sensory polyneuropathy is the most common type of neuropathy that we see in patients with HIV, right? So people living with HIV, the most common nature of peripheral neuropathy is distal sensory neuropathy, polyneuropathy, right? Okay. Now exam wise, MCQ wise, they've asked the risk factors for development of neuropathy, peripheral neuropathy in patients with HIV. So we will be addressing that today. Okay. Now before we address those risk factors, what is the additional manifestation that we might see in HIV with respect to CNS? We have already heard this term, right? AIDS dementia complex, right? AIDS dementia complex. Like this is an archaic term today. So today we use the terminology called HIV associated neurocognitive disorder, or what we call as HAND, right? And this HIV associated neurocognitive disorder has an entire spectrum. On the milder end, patient is asymptomatic, but on testing for the cognitive dysfunction, we will be able to see some degree of cognitive dysfunction. And on the severe end, patient is fully dementic, right? What is akin to or comparable to AIDS dementia complex. And this classification to mild, moderate to severe end, the classification is based on a criteria called as Frascati criteria. Frascati criteria. So this can also be asked as an MCQ. Frascati criteria is concerned with HIV associated neurocognitive disorder, right? Okay. So let us go through this Frascati criteria. So according to Frascati criteria, the HIV associated neurocognitive disorder can be of three types: asymptomatic neurocognitive impairment, mild neurocognitive disorder, and HIV associated dementia. This is what in the past we used to call as AIDS dementia complex, right? Clear? Okay, so let us look into this Frascati criteria. What is the asymptomatic neurocognitive impairment? So in asymptomatic neurocognitive impairment, you can compare it to what we also call as mild cognitive impairment when we talk about the dementic disorders, right? So what is mild cognitive impairment? Mild cognitive impairment is a condition where if you test patient's cognitive function using the mini mental status examination or various tools available to you, patients will have some evidence of cognitive dysfunction. But patients will not have any impairment of their activities of daily living. They are independent, they are able to carry out their activities of daily living unfazed. So such patients we call it as mild cognitive impairment. When you have cognitive dysfunction evident on cognitive assessment tools, and this cognitive dysfunction is causing impairment of activities of daily living, that is where we call it as dementia, right? That is with respect to dementia. Now here, asymptomatic neurocognitive impairment is comparable to what we call as mild cognitive impairment, right? So what are we seeing here? Here there is evidence of cognitive dysfunction on the assessment tools, right? Where patient has a cognitive decline below one standard deviation below the mean for normal population in at least two cognitive domains, right? So you are assessing various cognitive domains on at least two cognitive domains, right? Patient has his cognitive grade at least one standard deviation below the mean of the normative population or the comparable general population, right? So we have some evidence of cognitive decline on the assessment tools, but this cognitive decline is not affecting, no interference at all with the patient's activities of daily living, right? He himself comes to your OPD, he himself shows you, he himself follows all the advice you suggest, right? But when you use these cognitive assessment tools, you will unearth some degree of cognitive dysfunction, right? This is what is called as asymptomatic neurocognitive impairment. Okay, this is the milder end of the spectrum. In the middle range, we have this mild neurocognitive disorder. So the cognitive dysfunction on the cognition assessment tools is similar, one standard deviation below the mean of the normative population on at least two cognitive domains, same as your ANI. The only difference here is some mild degree of interference with the activities of daily living is what we are seeing here. Okay, now what is HIV associated dementia? Here there is marked interference with respect to his activities of daily living, like almost someone who needs to be told to what needs to be done, right? Like literal dementic patient, HIV associated dementia. And on the cognitive assessment tool, instead of one standard deviation, here patient will have a significant decline. So his cognitive function will be lower than two standard deviation below the mean of normative population in at least 2 cognitive domains. So in case of mild cognitive disorder, mild neurocognitive disorder, MND and ANI, we are talking about 1 standard deviation below the normative mean. Here we are talking about 2 standard deviation below that, right? This is the Frascati criteria. Okay, so after the Frascati criteria, now let us talk about the risk factors for peripheral neuropathy. We addressed the HIV associated dementia. Now let us address peripheral neuropathy. What are the risk factors? HIV infection itself is a risk factor, but what additional risk factors we need to know, right? So the common risk factors for peripheral neuropathy in HIV patients include advanced disease. As I've already told you, HIV itself is a risk factor. More advanced the disease, more long-standing the disease, higher the viral load, they are all definitely risk factors, right? Apart from that, patient's CD4 count less than 100, staggeringly high risk of peripheral neuropathy. Viral load more than 10,000 copies per ml, high risk of peripheral neuropathy. Having history of neuropathies in the past, using neurotoxic drugs is a risk factor, right? Nutritional deficiency, we all know, particularly the B complex group of vitamins and their role with respect to nerve function. So if they have nutritional deficiency, their risk of developing neuropathy is high, right? Then history of tuberculosis, because tuberculosis, yes, it increases the risk of peripheral neuropathy, but apart from that, a lot of anti-tubercular drugs have a neurotoxic property. So that explains why there is increased risk. Okay, diabetes per se causes neurological injury. So diabetes can be associated with risk. Hypertriglyceridemia, co-infection with hepatitis C, and alcohol abuse, right? All of these are considered as risk factor for peripheral neuropathy in a HIV positive individual. Okay, so that was about the neurological manifestations. Now coming to the next domain, that is respiratory system. So in terms of respiratory system, there are two things to address. One is pneumocystis jirovecii pneumonia and tuberculosis. If there is an MCQ asking what is the most common opportunistic infection in patients with HIV, right? The answer is not pneumocystis jirovecii infection, right? If you remember, we had that table and where we were talking about CD4 count. So CD4 count less than 500 is where we start talking about tuberculosis, right? And CD4 count less than 200 is where we start talking about pneumocystis jirovecii, right? Pneumocystis jirovecii we start talking about when we are talking about a CD4 count that is less than 200. So obviously more patients will reach that CD4 count less than 500 stage and less patients will reach the CD4 count less than 200 stage. So pneumocystis jirovecii is going to be less common. The second thing is majority of the patients of HIV infection are already having latent tubercular infection, right? They're already exposed. Reactivation is much more common, right? So once the CD4 count drops below 500, there is reactivation of the tuberculosis, right? Okay, so tuberculosis is the most common opportunistic infection in India also, worldwide also, right? So overall, in a HIV positive individual, the most common opportunistic infection is tuberculosis. Clear? I'm not only talking about the respiratory system. Overall, the most common opportunistic infection is tuberculosis. Okay. So with respect to tuberculosis, HIV, TB co-occurrence, there is a dilemma. The concern is when to start ATT, when to start ART, because there is a problem. If you have tuberculosis and you are HIV positive, when you present to the hospital, mostly you don't have the classical florid manifestations of tuberculosis because some of the manifestations are related to immune response. For example, when we talk about exudative effusions everywhere, exudative meningitis, exudative effusions everywhere, all of that is mediated through interferon gamma, right? Interferon gamma. If there is immune suppression and interferon gamma cannot be released, then you don't have those florid manifestations, right? But once we start on ART, your CD4 count starts improving, your immune system starts building up. After that, all these immune responses which were suppressed to HIV and TB infection, they start becoming evident, right? This is what we call as immune reconstitution inflammatory syndrome, or IRIS, right? Now this IRIS, the patients who initially presented with no symptoms of tuberculosis now start presenting with exaggerated symptoms of tuberculosis, right? Particularly concerning our pulmonary tuberculosis and neurotuberculosis. So if they have tubercular meningitis, mostly they don't have signs of meningeal irritation at the time of presentation because the inflammatory response is not there. But once the immune reconstitution occurs, right? So interferon gamma production starts, there is cell-mediated immune response. So exudative effusion starts occurring. Now the concern with exudative effusion is it can rapidly increase the intracranial tension. So that can be catastrophic at point of time, right? So this IRIS is not only associated with increased clinical manifestations of inflammation, it is associated with increased mortality, right? It is associated with increased mortality. So we cannot let this happen. So how can we prevent that? So to prevent that, first let us get rid of the tubercular bacilli load and then start on the antiretroviral drugs, right? So how can we do that? We first start ATT and then start ART. When to start ART after initiating ATT is the question. And for that, we depend on the patient's CD4 count, right? If the patient's CD4 count is more than 50 to start with when we are starting the ATT, right? So at this point of time, you can wait up to 2 to 8 weeks to start ART. So you start ATT, 2 to 8 weeks later, you can start the patient on ART. So you started ATT, the patient's CD4 count at this point of time was more than 50, right? So more than 50 is like a reasonable number. When it is less than 50, it is as such, other opportunistic infections can kill the patient. If not tuberculosis, if not iris, other opportunistic infections can kill, right? So at that point of time, when the CD4 count is less than 50, we need to balance things out. But when it is more than 50, 2 to 8 weeks is the time that you can wait for initiation of ART, right? But if the CD4 count is less than 50, we have to balance things out, because as I've already told you, if the count is less than 50, if tuberculosis is not killing him, if iris is not killing him, the other opportunistic infection like MAC, right, or your CMV infections, they themselves can be catastrophic. They can kill the patient. Now we have to keep his CD4 count above 50, and the only way to bring the CD4 count up is to kill the viruses, right? So to give the ART. So at this point of time, we have to first we need to start ATT. But within 2 weeks of initiation of ART, we can't wait for 2 to 8 weeks. Within 2 weeks of initiation of ATT, we can start with ART. Clear? Okay. Now, if there is tubercular meningitis, there is a particular additional concern, right? If there is tubercular meningitis and if immune reconstitution occurs, right, such patients can have a very high amount of exudative effusion, right? And this can lead to increased intracranial tension, and this can be associated with high mortality. So we can't let that happen. So in patients with HIV-TB co-infection, if they are presenting with tubercular meningitis, we have to wait longer period of time before we initiate ART. So you start ATT 4 to 8 weeks later, you start ART, because tubercular meningitis as such needs longer duration of ATT for clearance. And second thing, we don't want the patient to have a immune reconstitution affecting the CNS, right? So 4 to 8 weeks after initiating the ATT, we will start with ART in case of tubercular meningitis. Okay, so that is the information we need to know about the HIV-TB co-infection. Now let us talk about the WHO's 3I strategy for prevention of HIV-TB co-infection. What is the 3I strategy? The first I in the 3I strategy stands for intensified case finding, right? Aggressively find out the TB HIV co-infection among HIV infected individuals, right? That is the first I, intensified case finding. The second thing is INH preventive treatment, because as I've already told you, a sizable chunk of HIV positive individuals will be already exposed to tuberculosis, so they are at risk of developing reactivation, right? So they might be having latent tuberculosis, they can develop reactivation, or they can catch tuberculosis infection, and it is better that we at least the latent tuberculosis let us clear it off. So for that, we offer INH preventive treatment, right? That is a second I. First I is intensified case finding, second I is INH preventive treatment, and the third I is very aggressive infection control practices, right? So when we talk about infection control practice in India, I think we should be talking more about hygiene, right? So these are important strategies according to WHO. Okay, so now that we are talking about INH preventive treatment, we should definitely know the regimen, right? So the regimen that is followed by NACO and the regimen that is recommended by WHO are different. The regimen that is followed by NACO is like all HIV positive individuals, right? It is talking about all HIV positive individuals, because all HIV positive individuals are at risk of acquiring or reactivating latent tuberculosis infection, right? So should be treated with INH prophylaxis if they have already completed 6 months of ART, right? HIV positive completed 6 months of ART, now he should be receiving INH prophylaxis, right? So the INH prophylaxis is given as daily drug for 6 months, right? For 6 months. This is the NACO recommended INH prophylaxis. Now, what is the WHO recommended regimens? WHO recommended regimens actually talk about combination treatments. So, what are the combination treatment? There are multiple regimens. The first one is just a short regimen, right? 1 month regimen, a combination of rifampicin and INH, right? So, here rifampicin and INH are given daily. The same regimen, same combination of rifampicin and INH can be given as a weekly dose, right? In that case, the regimen gets extended to 3 months. Rifampicin plus INH daily 1 month. Rifampicin plus INH weekly regimen duration is 3 months, right? Okay. Apart from that, instead of rifampicin, you can use rifampicin. So when you are using rifampicin, if you are using a daily regimen, rifampicin being substituted with rifampicin, then the duration of the regimen becomes 3 months. We are giving daily, but rifampicin is being replaced with rifampicin, a relatively less effective drug. So we are talking about 3 months. Okay. If you want to only use rifampicin, right, rifampicin alone regimen, then we are using it daily and for 4 months. Anyway, India does not accept rifampicin alone regimen because of the high risk of MDR tuberculosis, particularly among HIV individuals. So mostly we talk about INH prophylaxis, 6 months daily INH for all HIV positive individuals who have completed 6 months of ART. Clear? Okay. So that concludes our discussion on the respiratory system tuberculosis. Okay. Now coming to the next opportunistic infection, that is our pneumocystis jirovecii pneumonia. We have already addressed this point. CD4 count less than 200 is where pneumocystis jirovecii pneumonia starts becoming evident. So this is a AIDS defining illness, or according to WHO is the stage 4 infection, right? So this usually presents in the form of atypical pneumonia. So most of these patients present with what? Dyspnea and hypoxia. Dyspnea and hypoxia, which is out of proportion to what you see on the X-ray. It's a case of atypical pneumonia. So your X-ray may not have a florid picture, but patient is having dyspnea and hypoxia kind of out of proportion to the X-ray finding, right? If you do the HRCT of these patients, you will see ground glass opacities. It is a atypical pneumonia, so that's what we see on the HRCT. Chest X-ray may not show much of the changes, or may show some fleeting opacities. Okay. So how do we diagnose this? First thing is, for diagnosis, suspicion is very important. You have a HIV positive individual whose CD4 count is less than 200. If he's having dyspnea, hypoxia, cough, the first thing that should come to your mind is your pneumocystis jirovecii infection, right? So in a suspected case, we can get the bile fluid. Sputum is not very diagnostic. So you can take the bile fluid and do the silver staining to identify pneumocystis jirovecii organisms, right? That can be used for diagnosis. And as a quick screening tool, you can bank on what is called as 1,3-beta-D glucan, right? 1,3-beta-D glucan, right? So what is this? This is a marker of invasive fungal infections of 3 species, right? What are the 3 species? We have already addressed this point in our fungal infections video. So it is a marker. It is elevated in patients with invasive aspergillosis, right? It is elevated in patients with invasive aspergillosis. It is elevated in patients with invasive candidiasis, regardless of the species, and it is elevated in patients with pneumocystis jirovecii infection, right? Pneumocystis jirovecii infection. Clear? So in an HIV individual where you are clinically suspecting the possibility of pneumocystis jirovecii infection, doing this 1,3-beta-D glucan may be handy. Particularly having the normal values of 1,3-beta-D glucan are very useful. They have a very high negative predictive value. So if your 1,3-beta-D glucan is very low, it's not suggestive of a positive test. In such case, even if you're clinically suspecting, you are probably going to be wrong because it has a very high negative predictive value, right? Okay. So how do we treat these patients with pneumocystis carinii or pneumocystis jirovecii infection? The drug of choice is cotrimoxazole, right? So this is something that we all know. Drug of choice is cotrimoxazole. The duration of therapy for acute infection is 3 weeks. It is 3 weeks. So after that, we have to switch the patient to the secondary prophylaxis. Again, the drug of choice for secondary prophylaxis is cotrimoxazole itself. So patient should continue to receive cotrimoxazole until and unless his CD4 count improves beyond 200. Once the CD4 count goes beyond 200 and it is sustained at that level, maybe you can think of withdrawal, right? Most of the physicians prefer to continue the prophylaxis once they start on the cotrimoxazole, right? So if cotrimoxazole is contraindicated or a patient cannot tolerate, what alternatives we have? Okay, in the past we used to talk about a drug called as pentamidine, which used to be given as an inhalation, right? Pentamidine given as a inhalation. Well, we only spoke about it like when actually I had a patient whom I had to treat with cotrimoxazole because of the PCP pneumonia, and patient could not tolerate it. Patient in fact had some adverse events related to cotrimoxazole, and we tried to secure this pentamidine, and it is not to be found anywhere, right? We tried to reach out all major pharmacies in Bangalore, Mumbai, and we couldn't find it. It is something that was not readily available, right? So as an alternative, what we can use? We can use clindamycin plus primaquine combination, right? We can use clindamycin plus primaquine combination as an alternative regimen. Clear? Okay. Now, I want you to remember one more point with respect to pentamidine. Because pentamidine is delivered through inhaled route, well, it is reasonably effective in prevention of PCP pneumonia. But some of these patients sometimes can present with PCP pneumonia predominantly affecting the bilateral upper lobes. Because when we deliver this drug through the inhaled route, mostly it gets delivered more to the right lower lobe, then to some extent the right middle lobe and the left lower lobe. The upper lobes, the drug is unable to reach. So because of that, patients can present with upper lobe involvement in PCP pneumonia. So if it is a pentamidine treated patient, pentamidine prophylaxis is what patient is getting. And if they present with respiratory distress, if they present with hypoxia, and if their CD4 count is less than 200, you should still think of PCP pneumonia if there is bilateral upper lobe opacities or infiltrates. Clear? Okay. Now there can be another MCQ asking you what is the role of steroids in patients with PCP pneumonia or pneumocystis jirovecii pneumonia. Right? So steroids are currently indicated if there is evidence of hypoxia defined as PaO2 less than 70 millimeters of mercury or alveolar and arteriolar oxygen partial pressure gradient more than 35 millimeters of mercury at room air. In this case, you can add prednisolone. Clear? So it is only indicated if there is significant hypoxia. Otherwise, routine use of prednisolone in PCP pneumonia is to be discouraged. Okay. Now, we have addressed all the systemic manifestations and some key opportunistic infections. I do agree that some of the things like toxoplasmosis and all need to be covered. We will be addressing through separate videos, right? Okay. So now we come to management of HIV. The basic pharmacotherapy and the classification is already something that we have discussed in the very beginning of the session. Now let me restrict only to deciding what is the indication for initiation of ART and what are the regimens that are approved by NACO. There are regimens approved by WHO, there are regimens approved by the American CDC, and there is no perfect match, there is no perfect sync. So for an Indian patient, we should be talking about NACO regimen only, right? Okay. Now, when I was an undergraduate student, it was such a headache to try remembering indications for initiation of HIV, ART, right? And I used to feel proud of myself because I was able to remember or literally by heart all the indications for initiation of ART. So indication used to be complex, like, okay, CD4 count below this with this manifestation, yes, you will be starting with the ART, or CD4 count, absolute CD4 count less than this without any of these manifestations, you will be starting them with ART. So this used to be the standard template of indications for initiation of ART. So it was complex. So with passage of time, things have become much more clear, right? What is the clarity we have now? All patients with HIV should be treated with ART, right? So ART is indicated for all patients with HIV, and earlier the better. This concept also stems from, we discussed this thing called as set point of the viral load, right? So you have higher set point, then you have a higher risk of progressing to HIV AIDS, right? So if we keep your viral load suppressed as much as possible, then your systemic manifestations and your risk of developing AIDS is less. And the earlier we control, we keep the lower set point, right? Lesser chance of progression to AIDS. If at all there is progression, very slow progression, right? So we should treat all patients before they have consequences of HIV replication on the tissues. Even if you are minimizing the risk of opportunity infections, having HIV replication itself can be associated with this HIV associated nephropathy, HIV associated cardiomyopathy, HIV associated with neurocognitive disorders. All of them are possible, right? Even if you are able to prevent somehow opportunity infections, HIV can cause harm, right? So we want to keep the HIV viral load as low as possible, if feasible, undetectable, right? So all patients should be treated. So good thing is we don't need to remember any indication for initiation of ART. The moment you diagnose it as HIV positive individual, that is the best time. Right? Today I have got a patient with test results confirmative of HIV. Today is the right time to start him on ART. Yeah, the prerequisites like your LFT assessment, RFT assessment, get that done and initiate ART as soon as possible. Earlier the better, right? Okay. Now what are the approved regimen? The NACO approved regimen is a combination of tenofovir disoproxil fumarate plus lamivudine plus dolutegravir, right? So 2 NTRIs plus a dolutegravir, right? This is a combination. This is a first line agent recommended. There are also recommendations for the alternative regimens which can be used in place of this TDF 3TC DTG combination, but then there's a long list of those regimens. I don't think we should be trying to by heart all of them, right? So if you remember the first line combination, that should be more than adequate. TDF plus lamivudine plus dolutegravir, right? Okay. Now we probably get a little better result if we replace this lamivudine with emtricitabine, right? So most US and the Western world regimens talk about emtricitabine in place of 3-TC. It's like TDF plus emtricitabine plus dolutegravir, but maybe cost is a concern for India, so we continue to use lamivudine in the regimen. Okay, what are the alternative regimens that, like the second line regimens that we need to remember? These second line regimens are not alternate regimens. Okay, so we have to remember that point. We're talking about second line regimens. These second line regimens will be used if the first line regimen shows a virological failure, right? So how do we define virological failure? Failure to suppress viral RNA copies to less than 1000 copies per ml. Right? So you start the patients on a particular combination of ART drugs, and if the patient's viral load doesn't get suppressed below 1000 copies per ml, then we can declare it as virological failure, right? Undetectable, that should be the ultimate goal, right? So virological failure is defined as plasma viral load greater than 1000 copies per ml. So in that case, you might have to think of switching from your whatever regimen you are treating to the second line alternatives, right? So what are the second line alternatives we need to know? If patient who has failed on, who was receiving azithromycin or stavudine plus lamivudine plus efavirenz or nevirapine combination, one of the archaic combination which was used for many years in India. So if patient is receiving this and he has landed up in virological failure, his viral load is more than 1000 copies per ml, in that case, such patients can be switched over to the most acceptable regimen to NACO as of now, that is 3-TDF. This is the first line regimen we spoke about, right? So your TDF plus 3-TC plus dolutegravir combination is what you can start. If patient was already on azithromycin or stavudine plus lamivudine plus efavirenz or nevirapine combination and they have failed, right? There we will be using the conventional first line regimen. Now, those patients who have been already exposed to tenofovir, right? Those who were receiving tenofovir plus lamivudine combination, and in place of dolutegravir, if they were getting efavirenz or nevirapine, right? The first line regimen is tenofovir plus lamivudine plus dolutegravir. If patient was receiving tenofovir plus lamivudine, but in place of dolutegravir, if patient was getting efavirenz or nevirapine, which also used to be one of the regularly used regimens in India. If such patients have developed virological failure, right, this regimen whole combination is unable to achieve the suppression of the viral RNA below 1000 copies per ml. In that case, what is our option? Right? We should be looking at patient's hemoglobin also. If the patient's hemoglobin is more than 9 grams per deciliter, we can think of adding azithromycin, because azithromycin is associated with anemia risk. If the patient's hemoglobin is less than 9 grams per deciliter, we cannot use this regimen, right? But if it is more than 9 grams per deciliter, you can use this combination, right? So we will retain lamivudine, we will kick out efavirenz nevirapine, we will kick out tenofovir, right? So we will retain lamivudine. From the first line regimen, let us borrow the dolutegravir because it's the good drug to use, right? It is an integrase inhibitor, and because tenofovir exposure is already there, let us not use tenofovir. Instead, we will use azithromycin, right? So we build this combination if the hemoglobin is more than 9 gram. If patient was on a very similar regimen, right, either tenofovir or abacavir plus lamivudine plus efavirenz or nevirapine, right, and such patients presents with virological failure and hemoglobin is less than 9 grams per deciliter. Like the same regimen, if the hemoglobin is less than 9 grams per deciliter, or instead of TDF, the regimen had abacavir and again the hemoglobin is less than 9 grams per deciliter. So in such cases, we cannot go to azithromycin, right, because it is associated with anemia risk. So what can we do? We use a combination of raltegravir plus lopinavir, which is ritonavir boosted, right? So we call it as lopinavir ritonavir boosted, that plus raltegravir combination. So in place of dolutegravir, here we are using raltegravir and we are using a protease inhibitor lopinavir, which is ritonavir boosted. So this regimen can be used if the patient is having anemia. So this drug combination doesn't have much impact on the hematopoiesis, right? So these are the regimens I want you to remember. So with this, I'm signing off our discussion on HIV. I do agree that this was not a very extensive discussion, but for the time we have, this is what we could have covered, right? If there are any more queries, please feel free to communicate with us on the Prep Ladders Facebook premium group. So having said that, let me sign off, wishing you all the best for your learning of HIV.